Here we go. So 4 components. S1, S2. We're knocked out to 2. MSC stands for mid-systolic click. That's the 3rd component. What's the 4th component? You see that orange shaded area? That's the murmur. 4 components. There you have it. 1, 2, 3, 4. What are you trying to do objectively to manage your patient? You're trying to take that murmur and you want to reduce the size of it. What do you call this? You see the bottom picture? The bottom picture on your right says delayed. What's delayed? The murmur. Or the click got delayed. It gets closer to S2. Says the murmur becomes very, very shortened. That is lessening of your intensity of that murmur. What does that mean? Delayed click. That click gets closer to S2. What happens as the murmur? You're squishing the murmur. And by doing so, you're decreasing the intensity of the murmur. What do you recommend as a doctor to that young lady? I keep saying young lady because that is who will be the most common presentation. A young lady with mid-systolic click, MVP. And by recommending exercise, which then increases preload, if you don't believe me, you ask any female out there that has an MVP and ask them what their doctor, if they know what they're doing, should be recommending. Exercise. If that doesn't work, if exercise is not compatible with your patient, then you start thinking about something that will cause delayed contractility. Maybe a beta blocker. Because if you have a beta blocker, what happens? Oh, heart slows down. Oh, I get that. Okay. And where's all my blood? Oh, in my heart. Does that increase preload? Correct. So what happens to the size of the murmur? The decrease. What happens to the click? It gets delayed. What happens to the intensity of the murmur? Decreased. Are you guys with me? Continue. Patients do not always have regurgitation. Is that clear? Because if it was, then you'd have a whole systolic murmur. Increased venous return delays click and shortens murmur. Highlight that in your head forevermore. Number 1 recommendation, exercise. That bottom picture shows exactly that. There's delaying of the click, shortening of the murmur. Voila, you manage your patient. Decreased venous return, not good. Let me give you an example with the maneuver. Valsalva phase 2. What are you doing? Ready for my face? Is that pretty? Well, it wasn't pretty to begin with, but I just made it ridiculously unacceptable. So I just had constipation. No, I didn't. Too much information. That was epiglottis, and I closed it, and I was trying to exhale. So what did I do? I increased my thoracic pressure, right? And then by doing so, you're compressing your pulmonary capillaries. At first, you increased it, no doubt. But phase 2, you won't have any blood left to then return to the left side. So it's decreased venous return to the left side. Decreased. So you have decreased venous return of Valsalva phase 2. What will happen to that click? It is early. And then what about the murmur? It is lengthened. Is that clear? What happens to the intensity of the murmur? It's increased. So the lengthening of that murmur represents increased intensity. The shortening of that murmur represents decreased intensity. If you've understood that much, there isn't a single question that you could possibly get wrong anywhere with dealing with these murmurs. We've walked through aortic stenosis, aortic regurg, mitral regurg, and MVP. A couple others that we have to walk through, but for the most part, there you have it. Now, what we have here is the following. I want to show you this. You're going to love this. This is about mitral valve prolapse, and then what happens to the 4 components. Now, what you look at here on the top picture is an individual standing up. Now, before we begin, I want you to think of the following. If you're standing up, where's my blood? In my legs. So what happens to venous return? It's decreased. When you have decreased venous return, there's decreased amount of blood in your heart. So therefore, what should the click look like? The click should be early. It should be right after S1. And if you take a look at what's in yellow there, and that click right after S1 is early. That's what that first line says. And then what about the murmur? It's lengthened and it's longer. The murmur is what you're seeing in the middle, and it is increased in size. Versus, let's say that you have rapid squatting. When you have rapid squatting, please understand that you're going to increase the amount of blood to the right side. And when you do so, you have increased preload. That click at this point is going to be late. The murmur will be shortened. And then we have hand grip. Hand grip is a little interesting. Earlier, when we talked about hand grip and referred to the physiology, if you do a hand grip, you'll increase your TPR. If you increase your TPR, you increase your afterload. your afterload is much more effective in hand grip than is preload, no doubt. If you increase your afterload, what have you done? You've increased the resistance of the left ventricle to eject blood. So there's more blood. Where? Well, you have more blood that you end up having in your heart. So therefore, it kind of behaves like your squatting episode, rapid squatting. You have a late click and you have a shorter type of murmur. You've understood mid-systolic click. You've understood the physiology of these different maneuvers, standing up, squatting, hand grip. Once again, you won't be able to miss a question. Let me ask you a question here, though. If it is aortic stenosis and you did a hand grip, what do you think happens to the intensity of the murmur? Take your time. Normally speaking, the blood should be moving. Now, this is not on this table, but not to worry. If you've understood the physio, then this part here should make absolute sense. Meaning to say, if you have aortic stenosis, crescendo, decrescendo murmur, I told you about calcification. If it's a young patient, bicuspid aortic valve, and if it's an older patient, senile dystrophic calcification. And normally, there should be a high gradient of blood from the left ventricle to the aorta. Are you with me? A high gradient. Normally, it should be ejecting blood only into the aorta. When you do a hand grip and you increase your TPR, what then happens to the gradient? It decreases. So there's less blood crossing a stenotic aortic valve. What happens in intensity of the murmur? It will decrease. Make sure that you work through this. If you haven't, and it's not making sense yet, please make sure you review this portion before moving on to the next section. This is not about frustration. This is about emboldening your ability to answer questions, to feel confident about what you're doing. When you walk into the ward, walk into any room in which your knowledge is being tested, you should be able to answer with utmost confidence and not feel bad about anything that you're saying because you know that you're saying it correctly. Confirm with echo, MVP. What are you seeing? The prolapse of the valve into left atrium. Asymptomatic, excellent prognosis. What are you going to recommend? You're going to recommend exercise. We talked about MVP. Now, the degree of MR determines the need for surgery. At some point, could MVP result in a holosystolic murmur? Sure. And at that point, you start thinking about, I need to provide surgical replacement.